I was saying the other group of tumors are your neuronal and your mixed neuroglial tumors. So these are tumors that affect both your neurons and the glial cells, like your astrocytes and your oligodendrocytes. So tumors in this category, for example, we have your central neurocytoma, which is purely a neuronal tumor, or you can have your ganglioglioma or this embryoplastic neuroepithelial tumor, the DNET, which is usually a mixed neural glial tumors. For the mixed neuroglial tumors, you'll see a mixture of mature neurons with the glial component, and they're usually composed of cells that will express neuronal markers such as your synaptophysin and your neurofilaments, and then also your glial markers like your GFAP. Normally, these tumors will present with seizures, and this will be seen in young patients. And the good thing about neuronal and mixed neuroglial tumors is that they're usually low grade, so WHO grade 1 tumors. So this is just an image to show you. This is what a central neurocytoma is. You see these small round cells. And then when you stain them with synaptophysin, it's going to be positive, and this is characteristic of your central neurocytoma. Then we have your embryonal neoplasms, and these are pediatric tumors that appear primitive or undifferentiated, although a limited degree of neural and glial differentiation is often encountered. The most common embryonal neoplasm is the medalloblastoma, which accounts for 20% of your pediatric brain tumors. So let's look at the medalloblastoma, which is a malignant embryonal tumor, so WHO grade 4, that occurs predominantly in children. The medalloblastoma exclusively is found in the cerebellum, so you'll not find it in the cortex. All are considered grade 4 tumors. They have rapid growth that may occlude the flow of CSF, and some patients may present with features of hydrocephalus. What causes you to form medalloblastoma? So there are various pathways that lead to it. So you can have alterations in the signaling pathways involved in normal cerebellar development, such as the sonic hedgehog patched pathway, the SHH, which is involved in control of normal proliferation of cerebellar granules, and in the WNT stroke beta-catenin signaling pathway. So you will see when you diagnose a medalloblastoma, you want to show whether it has alterations in your sonic hedgehog patched pathway, or they have mutations in your WNT stroke beta-catenin signaling pathway. So medalloblastomas in which the WNT pathway is activated are often located around the anterior fourth ventricle or middle cerebellar peduncle. For your sonic hedgehog activated medalloblastomas, these are most often involving the vermis and the lateral cerebellum. So on the basis of molecular alterations, your medalloblastomas can be divided into 4 or 5 molecular groups that vary in terms of age of onset, tumor location, and prognosis. They'll be found in the cerebellum, but different parts of the cerebellum, they will occur at different age groups, and each one of them will confer a different prognosis. So there are various histologic subtypes. For example, we have the classical medalloblastoma. In the classical medalloblastoma, tumors form homarite rosettes and often express neuronal markers such as your synaptophysin. They also express glial markers like your GFAP, and expression of your GFAP is less common. Then we have your desmoplastic or nodular medalloblastoma. As the name, nodular, it is characterized by internodular areas of stromal response marked by collagen and reticulin deposition, that is desmoplasia, with pale islands of nodules that have more neutrophil and show greater neuronal differentiation. So you're going to see nodules. Then we have the large or anaplastic medulloblastoma, which is characterized by large and irregular vesicular nuclei, prominent nucleoli. They'll also see cell wrapping, which is a cell-to-cell appearance, and they also have a high mitotic and apoptotic index. So you have high mitosis and also increased apoptosis. Morphologically, these tumors are usually of the cerebellar folia and involve the leptomeninges. Microscopically, you'll see very densely cellular tumors with sheets of small primitive appearing cells. These cells usually have scant cytoplasm. They have hypochromatic nuclei, and they are often they can be elongated, or they can be crescent shaped. Since these are grade 4 tumors, they have abundant mitosis, and they also have, when you put or you stain them with markers of proliferation, their Ki67 index is going to be very high, almost 100%, showing you that there is high mitosis. Medulloblastomas usually and you can have dissemination through the CSF as a common complication, giving rise to either extensive growth along the surface, likened to icing, or nodular drop metastasis, which will extend to involve the grow downwards to involve the cauda equina. Of course, you know from your anatomy, the cauda equina is usually found after around the lumbar sacral area. So this is just an image to show you. This is the cerebellum, and you can see this white tumor. Then when you take this tumor under histology, you're going to see this hypercellular tumor composed of these blue cells, homarite rosettes, and this is usually characteristic of medulloblastoma. These are your homarite rosettes. These dense areas surrounding a pale area, these are your homarite rosettes, and you can see from this the image on the left that these tumors are highly cellular. They have a lot of cells. This is the desmoplastic. You can see these nodules. We talked about the pale areas, and this is characteristic of your desmoplastic medulloblastoma. And this image is to show you the hypercellularity, also to show you how the cells look, the anaplasia. These are large cells, these are apoptosis, you have increased mitosis. So this is to just demonstrate that tumor morphology. The other tumors we talked about are your meningiomas, and we say these are tumors that arise from the meninges, hence the name. And these are predominantly benign tumors of adults that arise from the meningothelial cells of the arachnoid area. That is the arachnoid capsules. They're usually attached to the dura, so they're dura-based. Where they're found along any of the external surfaces of the brain, also within the ventricular system, where they arise from the stromal arachnoid cells of the choroid plexus. Meningiomas arise as a result of prior radiation therapy to the head and neck, typically decades earlier. And when you have patients who've had brain radiotherapy, then you want to monitor them because of the risk of development of meningioma. Other tumors such as metastases, solitary fibrous tumor, and a range of polydifferentiated sarcomas may also grow as dura-based masses, but majority of the dura-based masses are your meningiomas, and they will be well circumscribed. The most common cytogenetic abnormality associated with meningiomas is the loss or deletion of chromosome 22, especially the long arm of chromosome 22. And this is because it harbors the NF2 gene, in which this increases your chances of forming meningiomas. Of the sporadic meningiomas, 50 to 60% harbor mutations in the NF2 gene, and these tumors can also become high grade. Meningiomas without the NF2 mutation, then the KLF4, the AKT1, and the SMO gene mutations, and most such of malignant progression. So the ones that have the NF2 mutations have a better prognosis. How do meningiomas appear? They're usually rubbery, rounded, and buccellated dural masses that compress underlying. They may also grow in plaque in which the tumor spreads in a sheet-like fashion along the surface of the dura. And this form is commonly associated with hyperostotic changes in the adjacent bone due to invasion, although this by itself does not signify malignancy of the meningioma. So most meningiomas have a relatively low risk of being considered WHO grade 1 tumors. Meningiomas are divided into different types depending on what you see on histology. So they are histological subtypes. We have meningothelial meningiomas, which contain fuzzy or indiscernible cell membranes in that you cannot see the cell borders. We have fibroblastic meningioma, which has intersecting fascicles of spindled cells. We have transitional meningioma, which is usually a mixture of the meningothelial and the fibroblastic features. And then also you're going to see what are called psammoma bodies. You can have psammomatous meningioma, where you have a predominance of psammomic calcifications deposited over pre-existing walls. So this is a meningothelial meningioma formed by the meningothelial cells. And then the thing about the cells is you can barely see what separates one cell from the other. So their cell membranes are not discernible. So they give you what is called asyncytial growth. You can't see where one cell starts and where it stops. So this is characteristic of meningothelial meningioma. So this is just to demonstrate this is a dura, and then you have this tumor that is growing from it with dural attachment. And then the image on the right is to demonstrate the psammomatous meningioma, where you have these concentric rings. So this, when you see this in this tumor, then you call this a psammomatous meningioma. Meningiomas can also be WHO grade 2 or grade 3. So for WHO grade 2, we call them atypical meningiomas, which represent about 25% of the meningiomas and are associated with higher recurrence rates and more aggressive local growth, which may require radiation therapy in addition to surgery. They're usually distinguished from the lower grade meningiomas by having an increased mitotic index. They're going to have brain invasion, and they're also going to have other aggressive features. And also the cellularity in a typical meningioma is usually increased as opposed to what you see in the low-grade meningioma. Certain histologic patterns like your clear cell or chondroid are considered WHO grade 2 by definition because they have a more aggressive behavior. For your anaplastic meningiomas, which are WHO grade 3, these are highly aggressive malignancies that often resemble a carcinoma or a sarcoma, but retain some evidence of meningothelial origin. They account for about 1 to 3% of all meningiomas and may arise de novo. That is without any risk factor meningiomas. For anaplastic meningiomas, the mitotic rate is oftenly markedly elevated. Rhamnoid give them the WHO have a high mortality rate. So this is just to show you this is an anaplastic meningioma. So you can see the cells here are packed. You have increased cellularity if you compare it to earlier. Then of course, when you look at the mitotic activity for the WHO grade 1, you can look at an entire tumor and not see a mitotic activity. But once you start seeing increased cellularity and then the mitotic rate is elevated, usually count high power fields, and then you see how many mitosis you see in those high power fields. This will now give you the diagnosis of these cells now are starting to appear anaplastic. There's increased size of the cells, they're hyperchromatic, they're pleomorphic, and then you have increased mitotic activity. This is usually characteristic of anaplastic meningioma. So based on the histologic subtypes, your meningiomas are divided into either grade 1, grade 2, and grade 3, which I've gone through. So grade 1, your meningothelial fibroblastic transitional sarcomatas. There's even angiomatas, microcystic, secretory. For your atypical, the chondroid, the clear cell, the atypical, the anaplastic, you have the papillary rhamnoid, anaplastic, or malignant meningioma, so based on the histologic appearance. Then we say that the most common brain tumor are metastatic lesions, and mostly these are carcinomas, and these account for approximately 1/4 to 1/2 of the intracranial tumors. We say 25 to 50% of your brain tumors are going to be metastatic. So the 5 most common primary sites, we said lung, breast, skin, kidney, and GIT, which account for 80% of all metastases, and then the other 20 can be any of the other tumors. Of course, lung giving you majority of the metastases, with about 30%. Some rare tumors that can metastasize to the brain are your choriocarcinomas. For your prostate adenocarcinoma, it almost never metastasizes to the brain. So prostate cancer rarely metastasizes to the brain. The meninges are also a frequent site of involvement by metastatic disease, where they may either form discrete masses or are more disseminated subarachnoid. They can even give you meningitis like pattern. Then we talked about diseases or conditions that are associated with an increased risk of neoplasms. Here we've talked about neurofibromatosis. We've mentioned it, for example, with your meningioma, with your ependymomas. We have your schwannomatosis, your tuberous sclerosis complex, and your von Hippel-Lindau syndrome. Of course, with your neurofibromatosis, these are familial autosomal dominant syndromes, and these ones are going to predispose you to vestibular or cranial nerve 8 schwannomas. They can give you multiple meningiomas. They can also give you ependymomas of the spinal cord. For your schwannomatosis, this will give you non-vestibular schwannoma either throughout the body or in that will be limited to one region. So when you see a schwannoma in the brain or anywhere in the spinal cord, this is what a schwannoma called Anthony A, Anthony B. So when you see this on histology, this is usually characteristic of schwannoma. I just put it there. It's not a must that you know. For your tuberous sclerosis complex, also is an autosomal dominant syndrome found in about 1 in 6,000 births. So this is a bit frequent. For example, your subependymal giant cell astrocytoma, which we call SEGA, or cortical hematomas, but they'll also have lesions in other areas, like they'll have renal angiomyolipomas, they'll have pulmonary lymphangiomyomatosis, or cardiac rhabdomyoma. So they also have, apart from the brain tumors, they also do have other lesions. Then we have the von Hippel-Lindau disease, also an autosomal dominant disease. Patients with this usually will have mutations in the von Hippel-Lindau protein. They're predisposed to having hemangioblastomas in the CNS, but they also do have other lesions, like they have renal cell carcinomas. I'm sure this was mentioned in your lecture on renal cell carcinomas, and also they're predisposed to having pheochromocytomas. So they'll have mutations in the hypo-induced factor HIF1 gene. I think that's it. Any question? Okay, if there's no question, I'll assume that cerebrovascular disease and brain tumors are well understood. Enjoy the rest of your day.